Okay, great. Well, welcome everyone. Good afternoon, good evening, good morning, wherever you may be in the world. Thank you for joining us for this pituitary case discussion workshop, Perspectives from an Endocrinologist and Neurosurgeon. My name is Dr. Melanie Haynes. I'm an endocrinologist in the neuroendocrine unit at MGH. And I would like to take a moment to introduce Dr. Dichtel and Dr. Jones before they take it away. So Dr. Laura Dichtel is an assistant professor of medicine at Harvard Medical School and endocrinologist in the neuroendocrine unit and the Neuroendocrine and Pituitary Tumor Clinical Center at MGH. She completed her internal medicine residency at Brigham and Women's Hospital in Boston, followed by her clinical and research fellowships at MGH. Her research primarily focuses on the care of patients with pituitary disorders and the impact of growth hormone dysregulation on non-alcoholic fatty liver disease. And in her clinical practice, she primarily cares for patients with pituitary tumors and other pituitary disorders. Dr. Pamela Jones is an assistant professor of neurosurgery at Harvard Medical School and a neurosurgeon in the Department of Neurosurgery at MGH, who cares for people with all types of brain tumors, specializing in pituitary and paracellular tumors. She did her residency in endoscopic skull base fellowship at MGH, took her first faculty position at University of California, San Diego, and then we were fortunate enough to have her return to MGH to join the neurosurgery faculty and the Neuroendocrine and Pituitary Tumor Clinical Center in 2017. Her research focuses in translational and clinical efforts to study aggressive pituitary tumors. I'll be moderating the workshop today, so if you have questions as we go along, feel free to put them in the chat, and then I will present them to Dr. Dichtel and Dr. Jones. And with no further ado, Dr. Dichtel and Dr. Jones.
Great. Well, thanks so much, Dr. Haynes, for introducing us. We're really glad to be here.
Yeah, thanks very much. Excited to be with you all.
Great. So we'll just get started. We're going to try and keep moving because we have a lot of cases and we sort of find that we're tend to run out of time. So we're just going to try and keep it moving for you. These are our conflicts of interest. They'll be on the slides later. Great. And so we really want to mimic what we do every week together, which is our neuroendocrine and pituitary tumor multidisciplinary clinical case conference. And so in reality, we have this conference weekly, and it actually includes more than just an endocrinologist and the neurosurgeon. We also have our radiation oncology colleagues, radiologists who specializes in pituitary imaging, neurologists and psychiatrists, and also our specialized nursing staff that helps us discuss difficult cases and really give these patients the best care that we can. So we're going to model a little bit how we discuss some of those patients.
Absolutely. So initial presentation of pituitary tumors can vary broadly. Incidental finding is a very common way for them to be discovered, given the increase of head imaging with either CAT scans or MRIs for various complaints, be it trauma or increased headaches. Another is, of course, extra hormone secretion from the functioning tumors that could cause Cushing's disease, acromegaly, or TSH secreting tumors. And then symptoms of mass effect, which often is visual complaints, visual acuity problems, visual field cuts in the vast majority of cases. So these are the ways our patients often present to us.
So as the endocrinologist, my approach to workup is really actually first to think of mass effect. And so if my neurosurgery colleagues, if Dr. Jones is not already involved, we definitely want to consult with our neurosurgery colleagues as well as neuro-ophthalmology. Then we like to think about, is there diagnostic uncertainty? And this can also be worked up with our colleagues in neurosurgery, neuro-oncology. Sometimes these patients need further workup, including biopsies or lumbar punctures. And, sometimes this is a little bit based on imaging. And so we do a lot of imaging review. Does this look like a typical adenoma? Is it presenting like a typical adenoma? Or not. And so we have a lot of discussions in that vein. And then when I really get to the meat of the endocrinology questions is evaluation for hormonal overproduction, which we want to rule out with any pituitary lesion. And then also evaluate for hormonal deficiencies. And generally, we think of deficiencies developing when you have a lesion a centimeter or greater, but we also take an extensive history for just clinical correlation and any symptoms of hypopituitarism.
And for neurosurgeons, it's a very similar approach. We definitely want imaging, and we prefer an MRI pituitary protocol sequence. And this includes a key sequence of the T2 coronal image shown here. And so this is typically not done in just a standard brain MRI, and it's very good. This is where the fluid, or the cerebrospinal fluid, is white on a scan rather than dark as it is on a T1 scan. And it gives us a sense of if there's fluid in the lesion, and it also gives us a better sense of outlining of the optic nerves and optic chiasm. So we love a pituitary MRI when we're first evaluating our patients. We obviously refer to our colleagues in neuroendocrine for a full pituitary panel workup. And if there's mass effect, we refer them to our neuro-ophthalmology colleagues, as Laura mentioned. And then lastly, if it's an operative lesion, we're going to make sure that if they have any medical comorbidities, they get a medical or cardiac clearance. And if we have enough time, we want them to either reverse or with enough days preparation, stop their antiplatelet and anticoagulants.
Great. So we just wanted to share a little bit about the breadth of what we might see in the pituitary, because, some of our bread and butter lesions are pituitary adenomas or craniopharyngiomas, other cystic lesions. We see a fair number of meningiomas. We see also, though, malignant lesions to the pituitary. Patients have pituitary apoplexy or Sheehan syndrome. We rarely, but can see abscesses or infections, especially after interventions, but also infiltrative or inflammatory diseases can affect the pituitary. We follow patients after radiation or traumatic brain injury to make sure that they don't develop pituitary deficits. Also evaluate patients with empty-sella or even hemochromatosis. And then we always think of pituitary hypertrophy if we catch a glimpse of it during pregnancy or with hypothyroidism.
In a review of MGH cases done between 1998 and 2009, mostly done by a single, actually all done by a single neurosurgeon, my mentor, Dr. Brooks Orrington, who you may have heard speak earlier at this course. 92% were pituitary adenomas. So the vast majority of lesions that we operate on via the transsphenoidal approach are pituitary adenomas, but not all. So 8% were not adenomas. And of those 8%, the majority of those were cystic lesions, really Rathke's cleft cysts. The other lesions are benign neoplasms like meningiomas. So 2 were meningiomas that were thought to be adenomas. And then malignancies, so metastatic lesions mainly, that were thought to be adenomas as well. And then radiographically, the classic Rathke's cleft cyst was actually a craniopharyngioma on pathology, and vice versa. Those thought to be craniopharyngiomas turned out to be Rathke's cleft cysts. And then much less common, but important to remember, the inflammatory lesions, which were 9% of the non-adenomatous lesions.
Great. And just in terms of pituitary adenomas, it's a little bit of a review, but everyone's aware there's actually a high prevalence in autopsy studies, greater than 10% of pituitary lesions. And as we all know, the real big branch point is this prolactinoma, because we can treat that medically, or at least the first line treatment would be medical treatment. Whereas everything else, if there's Cushing's or acromegaly, or if you have a large non-functioning adenoma, you might need to go to surgery.
All right, so to review, before we get into our cases, I'm just going to review normal pituitary MRI imaging. So on the left, we have a T1 pre-contrast coronal sequence that is looking from front to back. So the ears would be off on the sides if we were in that plane, which we're not. The pituitary gland is slightly in front of where the ears would be. And this is where the pituitary gland is, and these black circles are the flow voids of the carotid arteries. This line here is the optic chiasm, where the optic nerves are crossing right over the pituitary gland. This is a T2 coronal. Again, the T2 is different from the T1 because the cerebrospinal fluid is white rather than black. And as you can see, this better outlines the fluid that's surrounding the optic chiasm. And so we can see when there's a lack of fluid and pressure on the optic chiasm. Post-contrast, the pituitary gland avidly takes up contrast, so it turns white on the post-contrast imaging, and pretty homogeneously as well, because the gland is homogeneous in its consistency. And here we see the pituitary stalk going up into the bottom of the third ventricle towards the hypothalamus. This is the sagittal or the sideways view on the right. Here we see the indentation above the nose and the nose coming out here. This is the forehead. And so these are the key sequences that we look at in terms of the pituitary protocol MRI. So no further ado, we'll get to our cases. And this is a new pituitary lesion that presented in a 63-year-old woman with several months of vision change. And she was found on exam to have a dense bitemporal hemianopia. She denied any additional symptoms. And so she underwent an MRI, which showed a sellar and sellar lesion with suprasellar extension and question of invasion into the left cavernous sinus where those carotid arteries run.
Great. So as we started her hormonal workup, we were able to obtain a prolactin that was 70, the normal being less than 23. So this was a few times above normal. The TSH was normal at 1.2 with a slightly low free T4, suggesting central hypothyroidism. The morning cortisol was 15, which is actually quite adequate. It's nearly adequate for a Cort Stim in our assay. And her IGF-1 was 125, which was within the normal range for a patient her age. And she had an appropriately high and elevated FSH for the postmenopausal range. And so we also actually, Dr. Jones and Dr. Sorensen had a very interesting case recently, which you might have heard about in the other session, with a very high prolactin causing the hook effect. So the prolactin actually looking falsely low. This prolactin was confirmed in dilution at 70. And we ask, what is the likely diagnosis in this case? Because if we are dealing with a prolactinoma, we can start medication. But if not, Dr. Jones would take this patient to surgery. And so when we think about this patient, if you have a patient with a new lesion and you don't have, any labs yet, you can think, well, where might the prolactin be? If it's less than 100, it's consistent with stalk effect. Studies have separated out patients that have macroprolactinomas versus the stalk effect. And the separation line is really about 94 or 100. And so if you have a patient with a prolactin below this range, it is likely stalk effect. If you have a patient with a prolactin above this range, it's likely an actual prolactinoma. And so you can actually use this to think about what your differential diagnosis is for a pituitary lesion. If you have a prolactin below 100, well, yes, that could be stalk effect. You could also expect to see a potential microprolactinoma on the MRI. If you have a prolactin, though, of even in the low 100s up to 200s, you can have medication-induced hyperprolactinemia that comes to this range, especially with Reglan and Risperdal. Some of these medications can't be stopped, but if they can, you can try and determine if it's just medication-induced. And then finally, again, the macroprolactinomas, we're going to see these levels above 100, and their studies have shown that if you have a level of prolactin above 500, that is very characteristic of a macroprolactinoma. And in general, the prolactin level reflects the size of the prolactinoma. So you can see a normal pituitary here with, we'll presume, a normal prolactin level. And then in the lower panel, you can see just a very small hypodensity, and that prolactin might be 50. It might be higher if you have a very, very efficiently producing prolactinoma. And then in the middle, that might be a macroprolactinoma, maybe just over a centimeter, maybe just around a centimeter, and producing about 250. And then, you can see more invasive lesions that are a little bit larger, and that one might be, greater, up into the hundreds, greater than 800. And then finally, you can have even larger lesions. So, unfortunately, we do have some patients that present with actual already visual compromise and these very large lesions, and these prolactins can be well into the 1,000. This patient's prolactin was 8,000.
So in our case, with a prolactin of 70, we presumed it was a non-functioning adenoma. And so we recommended surgery. She underwent successful surgical resection of the soft adenoma, as it turned out, and pathology was consistent with a non-functioning adenoma and pathologic staining. Her hyperprolactinemia and central hypothyroidism normalized postoperatively. Here, I just showed that our pre-op coronal image, as I showed before. Notice that the contrast is less avidly goes into the adenoma. So this is more gray than we saw with the contrast just going into normal gland, which is quite much white or brighter. This is an intraoperative MRI. And so here we see that the contrast is going in here, which is probably some normal gland, and contrast within the cavernous sinus. And this black circle is actually our fat graft that we placed in the sella to prevent against cerebrospinal fluid leak. And here is a 6-month post-op scan where the fat has kind of decomposed. And then you just see the normal gland has settled into the sella and the optic nerves are well decompressed above. So the transsphenoidal surgery is the most direct approach for sellar lesions, sellar and suprasellar lesions. And here's an illustration as to why. So we get direct access through the nose into this sphenoid sinus back here, and back from the main sinus cavity. And then the pituitary gland sits in the sella, which is sitting in the sphenoid sinus. And we can get to that via endoscope, which is where the camera and light is at the tip of a 4 or 5 millimeter endoscope that we actually place all the way through the nose and hold in the sphenoid sinus itself, and which offers a monocular vision from the lens of the endoscope. Or we can use a microscope, and the microscope light is actually just sitting outside the nose, and the nasal cavity is widened with a nasal speculum, and that provides binocular, because there's 2 lenses on the microscope for more 3D anatomy visualization. We use an intraoperative MRI in select cases where an MRI actually comes into the room with our patient still under anesthesia. So we can check on the resection and actually then perform more resection if necessary. This is nice for functioning tumors where you really just want the patient to go through one surgery. And so if there's any question with whether you've removed that tumor, you can get an intraoperative MRI and be very, confident that you might be curing their acromegaly with one surgery rather than taking them back for another, for a residual you didn't know was there. Studies have shown that high volume surgeons, it's important, they have better outcomes. So surgeons who do more than 50 pituitary or more than 50 transsphenoidal cases a year have improved outcomes. And then in our center, patients go home on post-op day 1 with routine post-operative hormone monitoring as an outpatient. I will warn you, I'm going to show some video. So if you do not like seeing blood or surgery or anything like that, you can feel free to look away from the screen for about 30 seconds. But this is what we see with an endoscope. This is the endoscope in that sphenoid sinus. This is the sella with the bone removed. And so this is what is called the dura, or the covering that covers all of our brain and also the pituitary gland. And this is a blade opening up in a cruciate X-shaped fashion, the dura over the area where the lesion is. And this is exactly what the case we showed of the non-functioning adenoma would look like. You can see that there's soft tumor already coming out even as we open. And then we just put in soft ringed curettes to sweep away the tumor and scoop it out. And so here we are with most of the tumor removed. And this roof is actually the diaphragm sella that's pushed upwards and is pushing up on the optic chiasm. And so when you remove the tumor, it actually then what you want to see, and which is the goal of the case, is that diaphragm prolapses down. And so this is no longer a tumor. This is actually a prolapsed diaphragm sella. And then we know, and then we're clearing, we're at the back wall, we have side walls clear, we have the floor clear, and then we know that the roof has fallen down. And so those, other than, making sure there's absolutely no bleeding, those are the goals of the surgery. And then we know that the risk of their visual compromise is removed in addition to removing the tumor.
Great. So thanks for showing us the videos. I think a picture is worth 1,000 words sometimes. And so we see all these patients in the hospital as the endocrinology team. And as Dr. Jones said, they go home the next day. So I'm going to tell you a little bit about what we do in our center for post-transsphenoidal hormone monitoring. I do want to stress though that, actually Dr. Salvatore, there's other review articles actually that talk about different, protocols or the care of the post-op pituitary patient. And probably if you ask 2 individuals at 2 different centers, you would get, different answers. I'm not sure that 2 centers do this exactly the same, but there is some combination of watch for either SIADH or formerly diabetes insipidus, now AVP deficiency. And so what we do is we instruct our patients to drink to thirst, not more, not less. This is harder for some patients than others. Diabetes insipidus or AVP deficiency is pretty obvious. And so patients know they tell their nurse if it happens, while they're in the hospital, and they have strict ins and outs monitored while they're in the hospital, and they know to call us once they go home. They have instructions to do so. SIADH is not so obvious. As you all know, you can actually tolerate a relatively low sodium, and then it can drop pretty quickly, and then you start to develop symptoms, maybe nausea, vomiting, confusion, headache. And so we actually do sodiums on post-op day 1, 4, 7, and 11 as routine to try and catch this. We don't routinely do a fluid restriction in all patients in our center, but there have been publications that suggest doing some sort of, fluid restriction post-operatively to prevent hyponatremia. And as you can imagine, the post-op day 1 sodium is as an inpatient, and then the other sodiums are done as an outpatient. So they go to the lab first thing in the morning. For the adrenal axis, we go ahead in our center and start prednisone 4 milligrams on post-op day 1. We presume that the patient is going to have post-operative adrenal insufficiency. But before we actually give the dose, we do get a cortisol level for the morning. And so if we have a morning cortisol level, either on any of these days, post-op day 1, 4, 7, and 11, when we're getting these labs, any level that's adequate in your assay. So ours used to be 18, and now it's just over 15. But any level that's adequate in your assay proves that the patient's own axis is intact. And if this morning cortisol is inadequate, they remain on this low-dose physiologic prednisone, and we do a quart stim at 6 weeks. And this is just important to note that after any acute insult to the pituitary, the quart stim is really not a viable test for about six weeks or so. You have to allow the adrenals to atrophy and to not be responding to the exogenous ACTH that you're giving. And so all the other hormone axes are reassessed at 6 weeks, the 6-week follow-up, which is standard. So we have TSH paired with free T4, IGF-1, prolactin, and testosterone as applicable. And then menses are followed clinically. And then just to mention, Cushing's patients have a much more complicated post-op transfernodal routine, just because we have additional cortisol monitoring and consideration. So we won't talk specifically about that today.
Great. And then there's routine surgical management as well. And that is patients get placed on sinus precautions, which really just means that we don't want them to be blowing their nose and putting pressure on our repair of the sella in that fashion. If they have to sneeze, then we tell them to kind of open their mouth and try and transmit the sneeze through their mouth. And we do advise them to avoid CPAP, although if they really can't sleep without it, we want a rested patient rather than them kind of being just completely fatigued post-operatively by not using their CPAP. But it is something we prefer, at least for as many days post-op as they can, up until a week, and then they can return. They'll have bloody drainage from their nose for a few days. That is normal. And so we remind them of that. And it's going to be worse when they stand up because the blood is pooling in their sinuses when they're laying flat, and then they get up and it just drains out through the natural gravity pathways. We do tell them bright red blood pulsating out of the nose is not normal. And that can happen anywhere from a few days post-op to several weeks post-operatively, especially in drier climates or drier weather. So if that's happening, we tell them to hold pressure. If it's not stopping, pack the nose, call our office, go to a local ER. Clear fluid dripping out of the nose when leaning forward is also not normal. So we have them collect this fluid for beta tau testing or to determine if it's cerebrospinal fluid. Severe headache, nausea, vomiting, stiff neck, light sensitivity is an absolute must that they call us or just come in. There's rare risks of infection, but these would be the signs of those rare risks. And so we don't want to take those lightly. Fat graft incisions, I mentioned the fat graft that we do, that can prevent the cerebrospinal fluid leak. So when we've emptied out the sella from the tumor, we put a piece of fat in, and that we harvest from the right lower belly through a very small incision. And so that's closed with absorbable sutures. Other centers do it a variety of different ways, but this is what we do here. And then we put little white steri strips on them that fall off after a couple weeks. And if they have nasal packing in, which we do, we encounter an intraoperative cerebrospinal fluid leak, we put extra reinforcement to prevent it from recurring postoperatively, but which luckily the risk of that is 1% or less. But they will have nasal packing in, and that has to be removed at 1 week in the ENT clinic. And they'll be on antibiotics while that nasal packing is in. All right, moving on to our case number 2. This is a 31-year-old healthy male with a new cystic pituitary lesion. He walked into the ER per recommendation of his eye doctor, reporting that he couldn't see car mirrors for the last 2 weeks. On confrontation testing, it definitely revealed a dense bitemporal hemianopsia bilaterally, and he denied any acute headache or recent headaches. And this is the post-contrast sagittal image here. And what's interesting about this is that there's a line exactly through the center of it. On further imaging on the T2 coronal, we see that this is bright inside, same as the cerebrospinal fluid in its consistency, and then some denser material inferiorly. And this to us, with the line down the center and this T2 coronal appearance, and the fact that the contrast really only goes into this solid tissue down here and along the top where the pituitary stalk is compressed, this suggests to us that this is fluid filled and that there's fluid layering out when this person is supine in the MRI scanner, and the different densities of fluid are creating a fluid level. And that shows up as that line. And so this is a cystic lesion filling the sella and extending into the suprasellar space.
Great. So actually, Dr. Jones and I were called to see this patient in the emergency room at the same time. And so on the initial workup, we're able to obtain some labs pretty quickly. The prolactin was over 2,000, and the testosterone was just below normal, 220. LH and FSH were suppressed around 5, and IGF-1 was 200. This was normal as 63 to 373. This is important to get an IGF-1 anytime you have hyperprolactinemia, because you can have co-secretion of growth hormone and prolactin. This patient's morning cortisol was 15.6. This was at the time in our assay just below sufficient, but actually a pretty good morning cortisol, suggesting that his axis might be relatively intact. And then we're lucky to have our Mass Eye and Ear colleagues and right next door, and so we can often get visual fields in some of these patients immediately, and you can see his visual fields with dense deficits bilaterally in the lateral fields.
All right, so Laura and I were both consulted on this patient, and so we had a vigorous debate over how we should treat this patient. And so I just want you to all think to yourselves for a moment how you would treat this patient. I, of course, recommended surgery given his dense bitemporal hemianopsia and inability to see car mirrors, and the compression in the suprasellar space of his optic chiasm.
Mm-hmm. And because this was a prolactinoma, even though it was cystic, we know that some of the cystic lesions can still respond. And so I offered cabergoline. We could try and aggressively dose cabergoline for a couple of days to see if we could pull that lesion off the chiasm. But in reality, sometimes things just sort each other out. So the patient was waiting for a surgical slot basically following the weekend. And so we decided to go ahead and start cabergoline as well. And so we did start. Great. And
yeah. Yep. So,
okay.
Go ahead.
Yeah. So, cabergoline, we dosed it, a relatively aggressively, here, initially. If you are concerned about a major CSF leak or other, we are not actually usually as aggressive, but in this patient, he was in the hospital. We were very comfortable monitoring him. And so on day 0, we did give him 1 pill of cabergoline, and that's when his prolactin was 2,000. On day 2, we gave him another pill. His prolactin had already halved to 1,000. He got another pill on day 4. And then by day 5, his prolactin was 661. And you can see he had repeat visual fields on day 4. And while he was having some clearing in those quadrants that Dr. Jones is pointing out, it was clear that he didn't have as rapid resolution as we preferred, and he did actually elect to go ahead and take the surgical slot at that time.
Yes, so he realized he was not going to be able to return to work very quickly if he waited to see if the medication continued to improve his vision. And so he elected to proceed with surgery, and it was a straightforward surgery of opening the sella and scooping out the more solid portion of the tumor and having the cystic fluid drain out. And so we did see the nice prolapse of the roof over this pituitary, the diaphragm come down. And here you can see the optic chiasm is up here with no tumor around it. This is on the intraoperative MRI. And so after the surgery, his prolactin dropped further to 249, which of course is not a cure, as macroprolactinomas are hard to surgically cure, given that they can be adhered to the walls of the dural walls. And so Dr. Dichtel spoke to him further about treatment for that.
Yeah, so he was continued on cabergoline just at a low dose, which he actually tolerated quite well. And so his prolactin came down to 76 at that time. And then 2 years later, I'll let Dr. Jones review the MRI, but it was stable with no obvious residual.
Yeah, nothing to surgically go after, in terms of trying to achieve a cure. This is his optic chiasm up here, well decompressed. This is the pituitary stalk, ever so slightly deviated to the left, and no bulky tumor.
And his prolactin was 63. He remained on cabergoline 1 pill weekly. He did have some nausea eventually that was limiting his dosing. And central hypothyroidism was persistent. So he was continuing on levothyroxine. And often in these patients that have continued hyperprolactinemia and then, also post-op from pituitary surgery, they can have continued hypogonadism, especially when you can't normalize the prolactin. And so his testosterone remained low normal, and actually it was, to a degree where, because he was young, there were fertility considerations, and we did not start testosterone at that time. And then, as you can see, his vision dramatically improved with his updated visual fields.
Great. So I think we'll move to case 3, which is a different cystic pituitary lesion.
Mm-hmm. Yeah, so this is a 24-year-old healthy woman, and she presented to her primary care doctor with headaches, galactorrhea, and amenorrhea for 4 months. And so the astute primary care doctor gets the prolactin, and it's 120, normal being less than 23.3. She denied vision changes, and confrontation testing in our office was normal, and all other pituitary hormones were normal.
And on her, this is a very zoomed in post-contrast coronal image of just the sellar region. And here's the lesion that's the hypo-enhancing lesion with the brighter uptake of contrast into the compressed normal gland over here. And then on T2 coronal, we see that it actually has a very bright appearance similar to cerebrospinal fluid, suggesting that it's cystic.
Great. Yeah. And so just going back to this, the prolactin level and the differential diagnosis, you may be wondering, well, she has a macroprolactinoma, why is the prolactin only 120? Why is it so modest? And we do know that this generally is true, that the prolactin level reflects the size of the lesion, but it can actually be a little bit lower than expected when you have a cystic lesion. Yeah, great. So cystic prolactinomas might have a lower total level for, lower level for total expected size there. So we started cabergoline at 1 pill per week and quickly increased to 2 pills per week. We did normalize her prolactin, and her menses returned. And her neuro-ophthalmology evaluation 3 months later showed slight pallor of the left optic nerve, indicating that she did actually have some compression at some point, but that was maybe being relieved, and we would continue to follow that. And that did resolve by 6 months.
And here on the MRI, we can just see how this is the original lesion. And then you can see that the normal gland is starting to expand as the lesion shrinks. And it's by 1 year follow-up, it almost looks like, except for this tiny little area of abnormality, that the gland has, reoccupied the normal space. Yeah.
And so we just want to point out that actually, treatment of cystic prolactinomas can be very successful with dopamine agonists. Just because there's a cystic portion doesn't mean that it won't respond. And so while some of these, like our first patient did have to go to surgery with a very large lesion, many of these patients can avoid surgery. And so this is a really nice waterfall plot from Dr. Faget in our unit. And he did a study where he looked at percent change in cyst volume from baseline. So this is the change in actually the cyst volume with dopamine agonist treatment. And he details below whether they got cabergoline, bromocriptine, or both. And the black bars are where the prolactin was normalized. And then anything below that zero axis shows a decrease in cyst volume. So you can see that the majority of these cases, the cyst volume did decrease with the dopamine agonist. And then maybe, well, I do see, Dr. Shore, did you want to stop for that question or?
Yeah, I think that this question is pertaining to case number 2. So the question is, why wouldn't you increase the cabergoline dose further to lower the prolactin into the normal range and thus further increase the testosterone level?
Yeah, so I think that that would be our ideal, and that's a really astute question. And I think we would ideally do that. This patient just did have some dosing limited by nausea, and so it's a little bit of give and take, and obviously we don't want to make him nauseous all the time. And so with that prolactin of 63 and the 1 pill weekly, he was able to maintain a low normal testosterone and hopefully some sperm production for consideration of fertility too. Yeah, thank you.
And there's another question that pertains not to a specific case, but a general protocol, I think. The question is, would you use prednisone post-op regardless of the basal cortisol?
That's an interesting question. Is the basal cortisol, I might not be understanding the question completely. We use it, so we use prednisone as long as we get a morning cortisol the next morning. And if that morning cortisol self-stimulated is adequate, we don't send the patient home on prednisone. And so we really base everything on the morning cortisol the next day. And if they don't reach an adequate level self-stimulated the next day, we actually will check, on those other days where we're doing sodium monitoring. So they basically have, 4 or 5 chances to come off the prednisone. When we get to the 6-week time period, we go ahead and hold the prednisone the morning of the court stim, have them come in, do the stim test, take their pill when they're done, and then we call them with the results and advise them on whether they pass the test or not.
Great. I think that addressed Colette's follow-up question about whether to stop the prednisone for the court stim test that it's held the morning of the test. And there's another question. Would you use Clomid for someone with low testosterone postoperatively?
Oh, I think that's a good question. I think we tend to look at the postoperative testosterone and also reassess a little bit later. We talked about maybe 6 weeks postoperatively where these other hormones are reassessed, and often reassessing prolactin and trying to make sure we're normalizing prolactin if we can. And then are often, and these patients with pituitary damage are often, if the patient is truly hypogonadal, or replacing with testosterone treatment or testosterone replacement of some type. Oh, great. Okay, so this is our last prolactinoma case, and this is prolactinoma in the setting of desired fertility. So this is a 36-year-old woman, otherwise healthy, and presents for care of, she had a known prolactinoma for many years, and she was on cabergoline. She was diagnosed, 2 years prior in the setting of irregular menses, had been taking cabergoline for a while now. When she was first diagnosed, her prolactin was 147. The MRI showed a microadenoma, about 5 by 4 by 3 millimeter, with leftward stalk deviation and no chiasm compression. This just was actually in the inferior of the gland. And she started cabergoline 1 pill weekly and had return of normal menses, and her prolactin did actually remain elevated, which is just a good teaching point. We don't actually treat to a total normal lab. We actually treat to symptoms. Has galactorrhea resolved? Have the menses returned? And so we can allow permissive hyperprolactinemia in that setting. And then she had a new partner, and she likely desires fertility in a year. So just a couple, pearls to take away. You'll have this chart as a reference, but when we think of the pituitary prolactinoma, we think of two things really. We think of the lesion itself, and then we think of the hyperprolactinemia, and then we think of the treatment options that we have in our, in our armamentarium here for these lesions, and it ranges from anywhere from observation to surgery. And so really, if you have, no mass effect or a microadenoma, and you have really no symptoms, no hypogonadism, fertility is not desired, you can observe those lesions, allow permissive hyperprolactinemia as well as long as the sex steroids are normal. For example, in a woman, if you have, you don't have mass effect, you're not concerned about the lesion, but you have hypogonadism, if fertility is not desired, and breast symptoms are not bothersome or tolerable, then you can use oral contraceptives. And again, allow the permissive hyperprolactinemia in the background. The dopamine agonist obviously will address mass effect and try and shrink down that lesion, where it also addresses hypogonadism, can restore menses, can restore fertility, and also improve breast symptoms. And then surgery and radiation are reserved for treatment-resistant lesions or dopamine agonist intolerance. So with this woman at our initial meeting, her prolactin was 54 and she was on cabergoline 1 pill weekly and she had normal menses. Her IGF-1 was normal. We did recheck that because she just came from another center. We wanted to make sure she didn't have a high IGF-1 and we didn't have those records. The MRI was slightly increased in size despite treatment. So is now just a little bit over 5 millimeters. The dimensions had increased up to 7.5 millimeters. And so we increased her cabergoline to 2 pills per week. In 9 months, she now really desires pregnancy. She's ready. And her prolactin is now normal on cabergoline 2 pills weekly, but the MRI is still showing the slightly increased size, now 6 by 7.5 by 6 millimeters. And so this is when we talk to our colleagues like Dr. Jones to say, this is a treatment-resistant prolactinoma and she really desires fertility. Should we do something more acutely about this?
Yes, so I saw her in consultation and yes, the MRIs had shown that this lesion, which is still, small, still microadenoma by measurements, was indeed growing despite treatment. And here is the T1 pre-contrast one where you can see some inferior pouching or remodeling of the sella. This is the post-contrast where the gland is taking up the contrast avidly, and then the hypo enhancement indicates the lesions right here. And this is sideways or sagittal view right here. So very anterior and central in the gland, which is kind of the dream for surgeons and endocrinologists for prolactinoma, because it's just higher rates of surgical cure when it's not located laterally up against the dura of the cavernous sinus, where it's more likely to have microinvasion.
And actually, if you go back to the one thing that I learned, I think from this case and some others, is that this patient has a relatively short sella. So we do worry that, and Dr. Jones can point that out. And what I mean by that is that she just doesn't have a lot of space between the top of her gland and the chiasm. And so we do worry about just sort of physiologic, hypertrophy during pregnancy in particular, and watch these patients pretty closely. But as you look at many pituitary MRIs, you will see just like some people are short-waisted, tall-waisted, or, different proportions. We find that in the sella as well.
Mm-hmm. Absolutely. And so I did offer her surgery and she agreed to it. And the prolactin was actually normal on post-op day 1. She did not end up having any hormonal abnormalities on post-operative testing, and then proceeded to attempt conception. And here's her post-operative MRI with just a little bit of, post-operative change here, but the lesion is gone. That's just packing material. So this is our little visual pause. This concludes the prolactin focused portion of our talk. And this is a beautiful picture on a sunny day, which we won't show you a picture of what it is right now in April here in Boston. But the Charles River Esplanade is this park. This is the Charles River. This is the Museum of Science. Here we are at MGH right here. And these are our Mass Eye and Ear colleagues that do our opto exams right here in this brown building. So if there are more questions to address right now, we can do that.
Yes, there's a question for Dr. Dichtel. Isn't it more likely for the lesion to disappear if you go up on the cabergoline dose and normalize the prolactin?
Yeah, so we do see, I think it has been shown, if patients normalize their if patients don't normalize their prolactin, you don't think that the lesion is necessarily, resolved. And you would want to watch that, and you would think that that is a more resistant lesion. But there are plenty of cases where you normalize the prolactin and there is just always some residual lesion there. So it does correlate sometimes. And those patients that normalize their prolactin might have a better chance of the lesion resolving and coming off the cabergoline in a sustained way in the future, but it doesn't always correlate.
Great. We have a few more questions about that case. One is, even if you treat to symptoms, when the patient desires fertility, do you still allow permissive hyperprolactinemia, or do you try to lower the prolactin to normal? Does even a slightly high prolactin cause a defective luteal phase, and might the patient do better?
Yeah. Great. So that's very astute as well. So yes, we do think that there are animal studies that show a defective luteal phase or a luteal phase defect and possibly implantation with hyperprolactinemia. My personal approach is that if you have a patient that hasn't tried on their own and they still have a little bit of mild hyperprolactinemia, but they are having normal cycles, it's a little bit of a conversation with the patient, and there's nothing wrong with them trying. The tendency, though, is that if someone's going through fertility procedures, we usually do normalize that, just because all of the effort and money and effort and time going into those fertility procedures, we do want to optimize things from the get-go. So if a patient is trying to conceive naturally, there's nothing wrong with letting them try. There's also nothing, wrong with trying to normalize as much as possible, I think.
Right. And I don't know if this question has more to do with the hormonal implications or potentially mass effect implications. I think we've addressed the hormonal implications, so maybe we'll take the perspective of mass effect. But could she have gone to pregnancy with a microprolactinoma, or maybe we'll just say a microadenoma?
Yeah, absolutely. So we don't, depending on where that micro lesion is, it doesn't necessarily mean we have to proceed with surgery. So as Dr. Dichtel pointed out, she did have that really short sella, but probably we just offered her visual field monitoring during pregnancy and been, gotten her through fine. It was more conversation with the patient that is, a more nuanced conversation with her about the fact that she had a tumor that was growing through treatment. And she just kind of wanted a clean slate as she entered into the next stage. And so that was patient preference, a growing lesion. So I think given the, a lesion that we knew was resistant to treatment and that was growing, the surgery was in her future at some point, and she just wanted to do it before having a pregnancy.
Yeah. And given that we stopped the cabergoline at the first knowledge of pregnancy, there are cases where we have to restart cabergoline during pregnancy, but, normally we would stop cabergoline during pregnancy. We would be concerned about some growth at that point because, if you maybe consider maybe the cabergoline was holding it at bay and it was just growing a little bit, but if we had stopped the cabergoline, would it have been growing faster? So there are some sort of theoretical possibilities we can't always predict, and we could have monitored her, but it's also a discussion with the patient and thinking about this was a really young woman. And as Dr. Jones said, probably facing surgery at some point in the future anyway.
Thank you. There's another question about if the patient can tolerate dopamine agonist therapy, what is the utility of an oral contraceptive pill?
Yeah, well, if they don't want to become pregnant, the birth control pill can be really important. So, sometimes it really is a patient preference. So when you start a dopamine agonist, and again, you have to look at the whole patient and the lesion size, and also what the symptoms are and whether there's regular menses. So if they can tolerate a dopamine agonist, that will actually make, for example, a woman much more fertile than she was. And some women, if they're not having any other, issues due to the hyperprolactinemia, especially some young women would prefer just to go ahead and take a birth control pill and have birth control, adequate birth control, and go ahead and not take cabergoline. There actually are women that end up on both. That would be an example of if you had a patient that chose the birth control pill as their method of birth control, but then also had some kind of, breast symptoms or either a lesion that we're treating or some other symptoms that we also needed the cabergoline. So it's also not wrong to give them together. But I think this is what I think is fun about prolactinomas, is that you really get to know the patient, get to know where they are in life and what what their goals are with fertility and other things, and just walk through which treatment is right for them.
Great. I see that there's two questions about specific cases that our attendees have, but I think there's also a follow-up question to the question you just answered, Dr. Dichtel. If you use the birth control pill, is there greater risk of increased tumor size?
I mean, not that we believe. I mean, if you have a lesion of any size, you'll be monitoring. If you have a sort of macro or something that's getting to a macroadenoma or anything that is, potentially getting closer to the chiasm, we will be, monitoring that and potentially discussing that with our colleagues. But we don't worry about putting these women on birth control just in terms of affecting lesion size.
Thank you. So one of our attendees has a question about one of their own patients. They ask, would you treat with cabergoline in a patient with hyperprolactinemia, a negative MRI, but an atrophic pituitary gland who has amenorrhea?
Yeah, I mean, I don't know about the atrophic pituitary gland, and maybe there's an ectopic pituitary tissue, hard to know, but I think you can also have idiopathic hyperprolactinemia. So sometimes we actually don't see something on the MRI and you still treat with cabergoline just for the hyperprolactinemia.
And I think this can maybe be jointly answered by Dr. Jones and Dr. Dichtel. This attendee has a patient who was diagnosed with a macroprolactinoma, 3 centimeters, at the age of 12. She's now 22, and on her MRI, her lesion is 6 millimeters. She's been on cabergoline 0.25 milligrams twice a week with a suppressed prolactin level of 1, and she wants to get pregnant now. Would you take her off the cabergoline or refer her for surgery?
Yeah. Do you want to comment on what it might depend on what the lesion looks like, to be honest, and where it is and what, how much space you have.
Yeah. And then if 3 centimeters to 6 millimeters is a great response, as is a prolactin level of 1. So if it's been at that size and there's no sign of developing resistance, then I think monitoring with visual fields is warranted. If there's resistance down the road in her lifetime, then surgery could be performed. But I think it's probably a case where, a microadenoma we can monitor with visual fields. But again, it depends on where it's located. If it's, it's right near her optic nerves, or if she is very little space between the top of the sella and her optic nerves, then and taking out that lesion would help that space, then surgery might be a role.
Yeah. And I think the other promising thing for her is that if you did see any, concerns on the visual field screening, you can restart cabergoline, and she was very responsive. And so that would seem like a good backup plan potentially.
Great. Right. I think we've addressed all the questions.
Great. Okay, so we're transitioning to a case of an 84-year-old on Lovenox who experienced sudden onset of headache, nausea, vomiting, and vision change. He was already legally blind in his left eye from a trauma in childhood. So his only seeing eye in his right eye was now 20/100, and he had a superior nasal quadrant vision only. He also had near total ophthalmoplegia. So he had dense ptosis and couldn't look inwards or outwards. The MRI performed in the emergency room showed this T1 intrinsic hyperintensity with heterogeneous enhancement. So very different from the other lesions we've seen with this patchy changes. So this is a large cellular lesion with this supracellular extension upwards more to the patient's left than their right in terms of the optic chiasm compression. Here's a T1 pre-contrast coronal, and we can see that there's white in the lesion, even without contrast. So we call that intrinsic T1 brightness, meaning without any contrast, there's already intrinsic brightness to it. And on the post contrast, you can see there's a little bit more brightness, some that was already there, and then some additional into the lesion, but a lot of it doesn't take up contrast. So it's very heterogeneous. And so along, this constellation of symptoms of acute onset headache, nausea, vomiting with vision change, and intrinsic T1 brightness, as we'll go on to talk about in more detail, we are concerned about pituitary apoplexy here.
Great. So this is, one of the endocrine emergencies that we, talk about. And so especially in the pituitary world. So this patient's random cortisol, he was relatively sick and his random cortisol is 5. And he actually was also subsequent to this given dexamethasone for Mass Effect by Dr. Jones's team. So really the adrenal axis is a little off the table right now, but we do want to basically presume that he's adrenally insufficient and make sure he doesn't just go off dex and tapers down to a physiologic steroid. And it's important just to remember that, again, this is just like the acute pituitary surgery. It's an acute pituitary insult, and you can't use the Cort stim test for about 6 weeks. So really you just have to use the random cortisol. And so the TSH was 1.5, free T4 was 1.2, prolactin was just slightly elevated at 30. IGF-1 was normal, and testosterone was 300, and LH and FSH were 4 and 5. You might ask why we get the full panel, because, testosterone might be low in the hospital. Sometimes we have this window in time, and these patients might actually have a hormone-producing lesion that predisposes them to apoplexy. And so if we saw that the IGF-1 was high, for example, on this, we might think they actually had acromegaly leading to apoplexy. And so that is kind of helpful, and it's a time point that you can't necessarily get again once the lesion has, basically bled and sometimes involuted without any intervention or pathology sample to your advantage. Great. I think we covered this. Really, you can look back at this slide later, but you just cannot interpret the Cort stim test during an acute event because cortrosyn is exogenous, and those adrenal glands didn't change from one moment to the next, and they will still respond to the exogenous ACTH if you give that. And so you have to allow them about 6 weeks to atrophy. And that's why we do our testing at these intervals that we do. So a morning cortisol or a self-stimulated cortisol is always a good measure to use if you are not able to do the Cort stim. And when in doubt, you can really actually put someone on physiologic steroids and wait that period and then Cort stim test them.
All right, so as Dr. Dichtel said, it's an endocrine emergency. We give steroids immediately, but also a surgical emergency in most cases, especially in someone who's blind in one eye already and is only seen in a nasal quadrant and has dense ophthalmoplegia as well from the impact of the apoplexy on the cranial nerves that control eye movement that run in the cavernous sinuses. And so we brought him, once we reversed the Lovenox, we brought him emergently to the operating room for emergent transsphenoidal surgery. And this is the post-op imaging with just some fat packing. You can see that actually the cavernous sinuses no longer have tumor in it. That's not because I opened up the cavernous sinuses and went and getting tumor out of there. This, as Dr. Dichtel said, these involute. So the main goal of this is to decompress the optic chiasm, get as much as you can out, and then the rest of the tumor is going to go away on its own over time, as you'll see on imaging in follow-up. Along those lines, so this, that was a surgical emergency, but not all apoplexy cases are surgical emergencies. And so this is a case of a conservative management of pituitary apoplexy. This is a gentleman who also presented with headaches, but once he got steroids, the headaches improved. And other than that, he had no visual complaints and no visual findings on formal neuro-ophthalmologic exam. And so this was his image in February of 2018. Basically, you can see the enhancement going into the pituitary stalk, but you can't see enhancement going into the rest of the tumor because it's dead. So he had symptoms for a few days before this imaging was done. So there's the contrast has nowhere to go anymore because it's not viable live tissue. And it did have Mass Effect on the optic chiasm here, but he wasn't having any symptoms. So we'd operate on a patient and not their image. And then just 6 weeks later, we got an image and it showed that this basically had gone away. And so this shows that conservative management of pituitary apoplexy is certainly a reasonable thing to do in the right clinical setting. And studies don't suggest any major endocrine differences in outcome either. So as I said before, we focus on that T1 intrinsic hyperintensity as a marker of possible apoplexy in the right clinical context. So someone coming in with headaches or new vision abnormalities, and you're really, if they just, it happened like an hour ago and they came in off the street into your ER, you might not see it, but several hours and really one day after symptoms start, you're going to start seeing that T1 intrinsic hyperintensity to signal that it's blood. And this is just a chart of the evolution of blood on T1 and T2 over time. But really, the patients are going to present in that acute to subacute phase, and so that T1 guide is going to be very helpful. Other things that cause T1 hyperintensity on MRI, so you don't want to be fooled that everything's always blood. Proteinaceous fluid can also be bright on T1 images. Fat can be bright on T1 images, and melanin. And so we'll get into some cases with this as well. This is a 22-year-old woman with 1 year of migraines who presented to the ER with severe migraine symptoms, including headache, nausea, gait disturbance, word finding difficulties, but her vision was very good at 20/15 bilaterally, and she had full visual fields. So she got a CAT scan to start, given these various symptoms, and there was a hyperintensity in her sella. So this was, just like a blood on a CAT scan is bright, this could possibly be blood. But then she follow-up imaging. And so this is a sagittal view, and certainly there's a hyperintensity in the sella here. T1 intrinsic hyperintensity on a non-contrast sagittal MRI. But on further pituitary sequences, we see that there's absolutely no contrast going into this. It's very homogeneous in its shape. And classically, it's a lesion that's situated between the anterior gland and the posterior gland. And so ultimately, the T1 hyperintensity was attributed to the high protein content of a Rathke's cleft cyst.
And so the endocrine workup showed a morning cortisol that was on the lower side, and she was started on hydrocortisone. The TSH and free T4 were both normal. The prolactin was just below the normal range, and IGF-1 was also normal. Again, we always want to rule out a co-secretion of growth hormone when we have, this patient doesn't have hyperprolactinemia, but you should always rule out co-secretion of growth hormone if you do have it. But we also want to make sure that, we aren't, that this really is Rathke's. It's consistent with the Rathke's, but it's good to get the IGF-1 also to show that she doesn't have growth hormone deficiency. LH and FSH are as shown.
I've had a patient with an image that looked just like a Rathke's cleft cyst, and they followed it, and actually she had a very ultimately mildly elevated IGF-1 when she started developing mild symptoms. So good point to review. So here, because of the hypoadrenalism and the setting of a lesion that was 1 centimeter slightly larger, I offered surgery. I did not offer surgery for her acute symptoms of migraine. I didn't think this was contributing to word finding difficulties or gait disturbance. And she understood that. And so that's what you counsel your patients, is that I don't think this is going to change your migraine history, but it will help you, potentially come off steroids. And so it was a Rathke's cleft cyst on pathology, and she was able to come off hydrocortisone. And interestingly, her migraines did resolve. So studies do indicate that headaches can improve, but we don't guarantee it. And it's not a definite indication for surgery in many instances.
And actually, one thing that's really helpful is to have actually a really practical discussion about that, because we get a lot of questions because often patients are getting scans because of headaches. And I feel like that's really helpful that, our neurosurgery colleagues are talking really practically about this, the expectation that, yes, some people's headaches resolve, but many don't. And so discussing the risks and benefits in that way.
Absolutely. All right, so here's another case to review T1 hyperintensity on MRI images. So this is a 68-year-old man who presented with new onset double vision, left eye ptosis or eyelid drooping, and fatigue. So on further questioning, he also reported that he had excessive thirst and urination. So in past medical history, on further review, he said, I've had melanoma. I had Mohs surgery 14 years ago. Then he had also had low-grade prostate cancer, and he had a recent prostate biopsy, and his PSA was 16. And so on endocrine evaluation, Dr. Dichtel confirmed diabetes insipidus or vasopressin deficiency. adrenal insufficiency, and hypogonadism. And then this was his MRI, which is T1 pre-contrast, sagittal. This is very zoomed in. Here's the sphenoid sinus, and this is the profile view with the pituitary stalk coming up, and it very bright. So that, this wasn't labeled, I would think this was post-contrast image. And then this is the T1 post, where you can see that, yes, appropriately, there's a bit more contrast going into the pituitary stalk, but really they look quite similar, which is odd. And as is his presentation, and so we discussed what should be the next steps in his management. So thinking about what's T1 hyperintense on imaging and his history, it didn't really, it wasn't blood, although he did have acute onset of all these symptoms. It was very discrete and not heterogeneous, and didn't have the time course of an apoplexy. It didn't look like proteinaceous fluid of Rathke's. Fat would be odd because that wouldn't lead to an acute issue. And so melanin, with his history of melanoma, was a concern. And so we did recommend biopsy, and it was revealed to be metastatic melanoma.
Yeah, and this patient, it's a good teaching point where, adenomas don't present with diabetes insipidus. And so if you have a patient with diabetes insipidus and you're thinking, oh, this looks just like a pituitary adenoma, sort of simple case, you really should rethink the diagnosis. And so this patient did have diabetes insipidus or AVP deficiency at baseline, but then steroids were initiated, and then the mild AVP deficiency worsened. And so started actually on PO DDAVP. And this is actually relatively common. The adrenal insufficiency protects against AVP deficiency and the loss of water. And so sometimes when you give steroids, you sort of see just sort of a exuberant or more obvious AVP deficiency symptoms. And we did not treat for hypogonadism. It was not an acute issue, and this patient had a sort of active prostate cancer issues.
All right, and that kind of concludes our discussion over intrinsic T1 hyperintense lesions on MRI. This is a picture of the first building of MGH, the Bulfinch building, where anesthesia was first administered in this top floor of this dome area, and this is the inside of it, the ether dome. And this is painting recreating the scene that's on the wall. So, any questions?
We do have a few questions. Maybe while the case is fresh in people's minds, there's a question I think about case number 7, why you decided to operate.
Oh, okay. Let's see. Case 7.
I think it was about case 7 because it came in at the very
really
beginning.
Only based on her hypoadrenalism. I would not have operated otherwise. I would have said, let's reimage, and with growth, I would have operated. I did not operate because of her symptoms of headache, but I really didn't think I was going to be operating. But this was once she was discharged, I determined that, your symptoms are not related to this lesion. She was discharged, and this was on outpatient workup a few weeks later. So we really felt that in the setting of a lesion it was slightly bigger than a centimeter, to decompress the gland and see if we could return her adrenal access.
Yeah, and she had a quart stim that was inadequate as well. And this conversation might be different if all the hormones were normal, but she wanted to get pregnant. Maybe you would also discuss surgery versus, observation. But it's, again, all in the context of if there's a hormone deficiency or if there's a mass effect concern that Dr. Jones has.
Thank you. And then we have 2 questions that aren't related to a specific case that you've presented yet. But the first one is a patient with a macroprolactinoma who got pregnant, stopped their dopamine agonist. Postpartum is breastfeeding. When would you restart the dopamine agonist?
Yeah, well, you can't restart if they want to breastfeed. So those sort of 2 things are entirely incompatible, because if you start a dopamine agonist, that can, will just reduce the milk supply. So I think that it depends on a lot of factors. We usually wait about 2 months or so for that physiologic hypertrophy of pregnancy and the pituitary gland to resolve before we re-image. I think if you have high concern that this macro, was really close to the chiasm, or you have a higher concern, you could image a little bit earlier. But usually we would try and monitor and, as much as you could, prioritize that breastfeeding for that brief phase. And then as soon as that patient is done breastfeeding, then reinitiate the treatment. And partially that you can have a macro that's right up against the chiasm. You can have a macro that's, far away and you're not too worried for a bit of time.
Thank you. There's a question about Cushing's disease. In a patient with Cushing's disease, do you give glucocorticoids pre and post-op?
Yeah, so I'll let you do pre or intra.
Yeah, we hold steroids. That's part of our timeout or huddle before the case. We huddle and discuss every point of the case, and we always hold steroids.
Yeah, and our post-op protocol is actually to start dexamethasone in these patients with a similar protocol of monitoring morning cortisols. It's a little complex. You do have to worry or watch for potential for delayed remission. So even if that for, the initial morning cortisols are not low, sometimes you worry they're going to drop later. And so you can often protect them with sort of just the physiologic dexamethasone. And we actually do use dexamethasone in this case because we want to be monitoring urine-free cortisols and late-night salivaries. And those we can still measure when someone is on dexamethasone. So it's a little beyond the scope today to talk about the exact protocol. But it's a good question because we have a similar yet adjusted protocol for the Cushing's patients.
We have one last question that came in. Any new treatments for prolactinomas?
Right now, not that I'm aware of, in terms of just sort of like routine treatment. The dopamine agonists are still the mainstays at this time.
Great, and that covers everything.
Q&A from May Reyes, rather than the chat.
Oh, I don't have access to the Q&A. I'm sorry.
Oh. Okay.
Luckily, two of them were both in the chat. So
okay. So I guess you can take May's question for other attendees. If you could please put the questions in the chat.
Here, I'll paste it in the chat while you address it. Yeah.
Well, it's more for you, but is a 7-year-old man who has a resistant macroprolactinoma status post-transpanoidal before and radiation, but the prolactin is increasing in levels, but no changes of residual tumor, which was small. He is on cabergoline high dose. Any opinion?
No changes in the residual tumor with the small. He's on cabergoline high dose. Any opinion? So 7-year-old man, resistant macroprolactinoma. He had TSS and radiation, but the prolactin is increasing. That is interesting. I would definitely watch it because you would be worried that we think of the prolactin as the canary in the coal mine. And so, is it going to be growing outside of the radiation field or, I would definitely keep a close eye on that. You can have a little bit of radiation leak prolactin leak after radiation. So patients without a prolactinoma can get radiation and then due to stalk effect. But it sounds like this person had a macroprolactinoma and the levels were higher than that.
Thank you. Two more questions. One is, do oral contraceptive pills raise prolactin, and are they contraindicated in a macroprolactinoma?
Yeah, so we kind of addressed this a little bit before, but they're not contraindicated in a macroprolactinoma. If you have a macro that you need to watch that anyway. We don't think of birth control as being contraindicated in that setting. But I think, you can see potentially a little bit of increase in the prolactin sometimes. There is some variability in the prolactin anyway. I will say that the prolactin levels the birth control levels that we now use, the birth control doses are much lower than, we used to use in some cases. And so they're probably affecting less than we might have in the past.
Thank you. And the last question is, would the dex given post-op in a patient with Cushing's disease suppress the serum cortisol and make it look falsely low?
Yeah, that's a great question. So it's all about timing, as is maybe all endocrinology is with labs and medications. So what we do is that we actually get that post-op day 1 lab, and then the patient gets the physiologic dose of dex. So yes, there's the potential that, because maybe dexamethasone, if they're a slow metabolizer, it might be affecting their sort of cortisol levels down the line. But if you remember that you'd be giving 1 milligram of dexamethasone the night before to suppress, a Cushing's patient and get an abnormal result, we just kind of take it where it is and interpret it where it is. And if they're not suppressed, that tells us a lot, and if they have if they continue to have elevated, morning cortisols or adequate morning cortisols, especially through that post-op monitoring time. But it's a great question.
Thank you. And how are we doing on time, Dr. Dichtel and Dr. Jones? We have 14 minutes left. I don't remember how many cases you have total.
Yeah, we probably will run out of time, but maybe we can get through this next bigger case.
Yeah, I think so.
Mm-hmm.
The other one, this is the last major case, and the others are just little vignettes of some things to think about. Of interesting, treatments.
So we'll just jump on in. So this is case 9, presumed pituitary microadenoma, and Dr. Jones can kind of outline the MRI there, but we had a 46-year-old woman with a baseline weight of 130 pounds and gained actually 140 pounds. So like doubled her body weight in the last 5 years, and also had 1 year of lower extremity edema. The 1 milligram dex suppression test was 18. I didn't put the dex level here, but it was adequate. Urine-free cortisols were actually relatively modest, just twice normal. Late night salivary cortisol was 180, which with a normal being less than 100, and a random ACTH was 55, indicating that this would be ACTH dependent. Yeah, thank you. Dependent Cushing's. And the MRI did reveal 4 to 5 millimeter pituitary lesion.
Yes. All right. So since we're looking at this person, left is on the right. And so there's this hypo enhancing lesion in the left side of the pituitary area. So what's the next step in management? Do we jump in for surgery? Well, we have to think about the rate of incidentalomas in patients. And so I, for one, don't jump in and operate in that, although it's obviously a very clear case of ACTH dependent hypercortisolemia. Up to 10% of the population could have an incidental finding of this type of lesion.
Yeah. So, I mean, how do we hormonally evaluate hypercortisolemia? We definitely want to confirm and establish that the hypercortisolemia is present. This patient had pretty obvious symptoms and had pretty consistent testing. Sometimes this can be a really frustrating journey for the patient and the physician. And I'm sure everyone has had patients where it's just not so clear or they're cyclic, but we do a lot of testing. And when in doubt, you repeat testing. And when in doubt, you repeat it again. And you continue to follow them clinically, take pictures if you can integrate those in your medical record and try and follow them. So we do dex suppression testing, but a lot of urine-free cortisols and late night salivary cortisols, as long as their sleep-wake is normal. And then you want to determine ACTH dependence, which is very important. And then if ACTH dependent, then is when you would obtain the pituitary MRI. And then you may need further testing with, we discussed with our neurosurgeons, how confident are we, what's the size of the lesion that's found. But we might need further testing to determine if this is a central versus peripheral ACTH source.
Yeah, so although Cushing's disease is going to be the most common cause of her symptoms at 80% of ACTH dependent hypercortisolemia cases, it's not clear cut given that it could be an incidentaloma. So in Cushing's disease, adenoma is only visible on MRI, and studies show 40 to 60% of cases. So I tell my patients only half are visible on an MRI anyway. 90% are going to be microadenomas. That includes the invisible lesions. And then 10% of people will have an incidental small lesion on MRI. So we do go by in our center that tumors less than 6 millimeters warrant proof of that they're the ACTH source with an inferior petrosal sinus sampling, which is an interventional radiologic procedure. So for an image like this, I would just, this is something that would need to come out anyway, given that it's about probably a centimeter or more, and it's impinging on the optic chiasm. So if you took it out and it didn't stain for ACTH, that person needed a surgery anyway, but likely it's, the source of ACTH. Here, this small lesion down here, it's not something you would jump in to operate on. So you would want further testing that small lesion is the source of ACTH. And here, this pituitary MRI, although it's kind of generally hypoenhancing, there's no clear-cut lesion. So you definitely need some guidance that there's ACTH coming from there, given it's an invisible or negative MRI. So the inferior pterygical sinus sampling, again, is an interventional procedure where the vein is catheterized and blood samples are taken under sedation, anesthesia sedation. So it benefits from that ACTH short half-life. So there's already a gradient between the ACTH level that you're going to measure near the veins draining the pituitary, which is drained into the cavernous sinus and then into the inferior pterygical sinuses, which we can actually access with a catheter. And so we try to challenge that pituitary gland to make more ACTH with traditionally a CRH challenge, but given that's not available in the US, we use DDAVP. And then we measure the change in ACTH levels. So we get a baseline measurement from the bilateral and pterygical sinuses and a peripheral blood. And then we measure changes over time. And a central source is confirmed when the levels of ACTH rise at a rate of greater than 3 to 1 of central to peripheral. And the NIH looked at 501 patients, and they also determined that lateralization of the lesion could be predicted in about 69% of patients. And that ratio, if the right is 1.4 greater than the left or vice versa, it predicted the lesion on that side. MRI, if there was a subtle MRI abnormality, that predicted the location of the tumor in 86% of cases. So we love this for predicting if there's a central source of ACTH. Lateralization is also nice, but if an MRI and the laterality of the IPSS don't match up, you're going to go with what the MRI says, just because in studies it shows that it has a bit more accuracy, which you'd imagine. Because venous anatomy can vary in terms of how much it's draining from each side of the pituitary.
And we did get a question, what do we use instead of CRH? Because we actually are not able to obtain CRH right now. So
yes, so we use DDAVP, absolutely. Yeah, and so here's her results of her IPSS, and we can see that the right rose, but the left rose robustly. We do test that to make sure they are hypocortisolemic the day of the test with either a late night salivary the night before or 24-hour urine collected the day before the test, and hers was high, and her ratio was 425 times elevated over peripheral and definitely more than 1.4 times on the left than the right. So it confirmed hypercortisolemia. We confirmed centralization of ACTH and lateralization to the left, which matched with the MRI. So then I offered her surgery, transsphenoidal surgery, identified the lesion, removed it, ACTH staining, and TPIT transcription factor staining was confirmed on pathology. And then we did testing, which showed remission. We don't have all those numbers to show you. But this is just general kind of post-op Cushing's follow-up.
Yeah. And I think I think for the sake of time, we won't go into the immediate post-op monitoring, but you do want to protect against adrenal insufficiency, and we empirically treat for that and assess for biochemical remission and understand that these patients can have a little bit of delayed remission, and that can actually be a dangerous period. You have to monitor them pretty closely so you don't miss that if you were not providing them with a steroid rescue. And you also then, once you assess for biochemical remission, you want to, then prove that their adrenal axis has recovered. So you want to show that they have normal adrenal function. And then once they have normal adrenal function, all is fair game to recur. And so you want to just, make sure that they're not going to recur over time. And so once they're in the normal range, then you start to monitor basically for recurrence as well.
All right. So in the remaining 6 minutes, we'll wrap up.
And we do have a few questions. So maybe it'd be better to take the questions.
Sure, yeah.
And then if there's more questions, I think Dr. Dichtel and Dr. Jones, I don't know if people can email you if we can't get to all the questions.
Absolutely. But our emails are at the end. These are also fast.
So there's a couple questions about IPSS and then a couple other Cushing's questions. Maybe I'll do the IPSS questions first, since we were just talking about that. So one is, any problems with using desmopressin in the IPSS? Does it affect the results?
Not that we found. Do you have a?
I feel like we've been proceeding for the past sort of just empiric experiential,
We had some issues early on, a year and a half ago or something, but we determined it was lab-based, but none since then. So no, so far we've had really, maintained interpretable results and high quality IPSS results with our interventional radiologists.
Great. And then the second IPSS question is, do you do the IPSS with Dex plus desmopressin?
No,
we do not. Just the desmopressin.
Yeah. And it is also really important, as Dr. Jones pointed out, you have to show that the patient is hypercortisolemic, they themselves are hypercortisolemic at the time of the IPSS. And so I see that also as part of my job as the endocrinologist to make sure that, I explain if the patient is cyclic, we have to watch out for that they're not getting a test at the time that they're low, if we can, try and figure that out, and just that they're doing the appropriate testing at the appropriate time.
Thank you. And then there's some questions from the attendees about cases of their own, I think. One is, can a corticotroph adenoma be cystic? This attendee has a patient with ACTH-dependent Cushing's and a 6 millimeter cystic pituitary lesion.
Yes, they can. Yeah, it's not, the most common. But yes, I've definitely seen cystic ACTH tumors. Some that actually, a couple in memory that were cystic lesions that I was operating on just based on size, which wouldn't be necessarily the case here, that were surprise ACTH staining tumors. So these were more silent. Yeah.
And that leads perfectly into the next question. How do you confirm the diagnosis of a silent corticotroph adenoma?
That's a great question. I mean, I can start and you can talk about your surgery and pathology if you want, but I actually, something I learned from our course director, Dr. Biller, is that I rarely let a patient go to surgery without having some form of Cushing's workup, because if you find after surgery that the, pathology is suggestive of an ACTH producing tumor, you can't go back and check what the cortisol levels were before surgery. There's always a chance that they weren't in full remission or that you could, start measuring after. But it's always better to have that information going into surgery. Theoretically, we might not do a Cushing's evaluation if a patient has 0 symptoms or signs of Cushing's. Not everyone in our clinic might actually do the same thing. But it's rare that someone doesn't have something that you could, morph into a symptom of Cushing's. But before a patient goes to surgery, I'm very, I'm doing some sort of Cushing's workup.
Great.
Yeah.
Sorry, did you have anything to add?
No, I have nothing to add. It's always interesting when we find that, when they are TPIT staining and ACTH staining, and we didn't expect it.
Next question is, what is the first treatment option in prolactin and growth hormone co-secreting adenoma?
Yeah, no, that's a great question. I mean, often the growth hormone trumps the prolactin, and you want to have a chance where if they have a operable lesion, that our colleagues and Dr. Jones can take them to surgery there. Yeah,
absolutely. I think that usually that means that they're a surgical candidate to try to have achieve remission for their acromegaly, or at least a lot of tumor debulking for easier control if it doesn't look curable. One case scenario which I encountered recently, where we're treating with cabergoline, is a case of a giant prolactinoma, just invasive through the skull base, and then it was picked up because she was having vision problems, and those are improving on cabergoline. The tumor is shrinking, but she actually ended up having an elevated IGF-1/2 with very mild features of acromegaly. But her IGF-1 has now normalized on cabergoline as well. She's not a good surgical candidate because of the invasive, large nature of the tumor. And so luckily cabergoline is working for her.
Yeah. Yeah. And we would, even if the patient went to surgery for debulking and then, if they were not in remission and they had some residual, we would obviously continue to follow and treat medically.
Thank you. So I think that wraps up all the questions, and it's now 6 o'clock on the dot. So we know that the slides are available to attendees with some of these bonus vignettes at the end. And here are Dr. Dichtel and Dr. Jones's email addresses if anyone has any further questions. But I just wanted to thank Dr. Jones and Dr. Dichtel for their expertise and excellent discussion, and also the interaction of the audience, I think was really sort of
thank
the
you guys.
discussion to the next level.
Yeah, you guys are
thank
thinking
you.
very well about your pituitary patients. So, and thanks to Dr. Haynes too.
Absolutely. Thanks, Dr. Haynes.